we need a larger burring. So better we clear all the bony window and start the burring and make a margin clear in our mind that we will burr how much area. Not do over burring and not do a burring more around the pars interarticularis and make it prone for further
Listhesis.
listhesis. हाँ कर लेना. So this is the only interlaminar space which Dr. Shubhendu is palpating. This, that is the lower lamina, that is the upper lamina. So we will make a larger window over here with great effort of Dr. Shubhendu. So, so the case we are showing today is not a beginner's case. If I think in according to me, this case should be started after doing some interlaminar discectomies over L5S1, then L4 L5, then L5S1 normal cases stenoscopic decompression, single level stenosis, not listhesis. Listhesis should be come later on when you became expert of stenosis, because there is some anatomical variation in the posterior field. If lower bone is going posterior, then you can have very epidural space very early at the lower lamina level. So you have to think according to the differences in anatomy
MRA.
here. So yellow thing visible is ligamentum flavum, and interlaminar window is more clearly visible now. Only this much.
The yellow structure that's visible is the ligamentum flavum. Looks yellow. Okay. This one. This part. This one? No, that's not the flavum yet. This is the flavum. That's the bone. That's the tissue over the bone. Lamina, that's the upper lamina. Yeah. This part is the flavum. Flavum.
So we are starting drilling now,
In this,
and we'll clear tissues as and when required. Starting drilling from our upper lamina, IAP junction, spinous process laminar area, and whatever we are looking should be drilled first, and then we must so which drill we are using? We are using cutting side protected cutting burr with mechatronic, with which shaver system is? Jishan, okay. So Jishan's shaver system provided by Eagle Medical System by Mr. Karan. सक्शन नहीं लगाना है यार इसमें. सक्शन क्लेम
that's the
करके
burr,
रखो.
the diamond burr.
So it is not a cutting, it is a diamond burr with side protection. There is many variation in burr systems. one is cutting burr, one is diamond burr, one is a diamond side protecting,
This is the flavor.
diamond tip protecting.
See, it's gone
and
inside. No, this part is the phlegm. Okay, this is the bone, which is where the burr they're drilling. No, that's the burr. Sorry, that's the bone, the lamina. Huh? No, they're not real diamonds. But this burr particularly has one
You are
feature
drilling the IIT.
where even if it goes, even if you have to put it on the phlegm, and even if you drill it, it won't drill any other structure apart from the bone, and it causes the bone. I mean, it turns the bone to dust. One second, one second. I'm just trying to. Once he brings it out a little. Patient, no, I think he's towards the right side of the patient. Sorry, yeah, sorry. He's on the left side of the patient. Hmm. Do- hmm. See, the face it will be towards him. The face it will be towards him. Hmm. Spinal cord. No, under this will be the spinal cord. You're going from posterior. I'll tell you, see. Look at him. Towards Dr. Shubhendu's sides will be the facet. The facet. Above will be one lamina. Phlegm also has got two layers to it. The outer one is the thick yellowish structure that you see. As you going, we try to generally what we try to do is we put one annulus cutter, try to create a space in the ligamentum flavum, and then remove the entire ligamentum flavum. Ideally, we see the both the layers also. The inner flavum will be a little more duller yellowish or less yellowish. See, he's again trying to put on the bone and drill the bone. Upper lamina. Hmm? No, we could not make out. It was too close. No, I couldn't make. Yes. Now where he's I mean, wherever he's sitting, that's the upper lamina. We use the RF now in case there is bleeders, no? See, now they've put a. Hmm? No, it's still the upper lamina, the edge of the upper lamina. this is a Carrison. Now he's trying to nibble the bone. It's the upper lemma now that he's removing now. Yeah, upper.
So
upper side.
he is cutting the upper lamina with the Carrison and making the window wider. Hope everybody is.
Yes,
Not
sir. Yes, sir.
missing.
We make out. We can make out.
What is this structure? Window?
That's the facet. See, if what he's come just now, no, outside this way. That's the facet.
IAP.
The interarticular
This is the
process.
facet junction.
Yeah.
So this is the lower part. We can clearly tell about the structure after clearing some more tissue. Yep. So he is just trying to clear the its spinous process and lamina, spinolaminar junction. He made the window in the upper lamina and
lamina.
IAP area. Now he will clear more. In
Just
the
now
medial
where he's
side.
put is the IAP area.
Yes.
The last place that he has placed it is the IAP area.
So whenever we are using the Carrison, we must put below the bone and move it sideways to clear the structure attached below it. Sometimes whenever there is a thinning of the dura and neural tissue, adherence with the lamina and flavum, they might come below that. So how he is clearing by sideways movement of the Carrison tip, we should see it.
If you
minutely.
try to actually pull the Carrison up, the structures below also will might get pulled up. So in most of these pathologies, whenever they are there, most of the times the dura is attached to the flavum also. So in these cases, there might be a tear of the dura in case we pull it up. That is why we need to always use our Carrison under surface of the bone and remove it from sideways. Chip the bone from sideways. I've seen one in this case. I mean, I've seen one case. Yeah, there are multiple things. One is um, there is. I mean, you seal it with a graft, or there is a gel that you use to seal it. If not, if the depending upon how big the rent is, sometimes you might have to suture it also. Depends. No, no, the neurosurgeon does it. Yes, yes, yes. Especially when there are calcified parts, very chronic cases, calcified, when the disc is calcified most of the time. I mean,
So are you using 2 mm or 3 mm punch, Dr. Shubhendu?
yeah, so I was saying there'll be 2 Carrison punches, there'll be 3 and then there'll be 4 So we use 2 for nibbling the bone. We use 3 for punching and removing the bone. So nibbling means we just kind of cutting it. It's very similar to kind of burring.
So currently we are using 2 mm Kerrison punch over there. In Kerrison punch, foot plate plays a very much role in his work. So foot plate should be thin,
Outer
thin as
flavor.
possible.
So face it. The inner surface of IAP. He's trying to drill there. That's the lamina and the IAP junction.
So we are using second irrigation fluid. We must keep a watch over the irrigation fluid numbers also. Many times we might end up using 8 to 12, 3 liter of NS, means 24 to 36 liter of irrigation fluid in known cases of posterior stenoscopic number decompression. So there is a many complication of the fluid irrigation also. If patient head is low and fluid irrigation pressure is high, then patient might end up in seizures, headache and other things because of larger volume of fluid absorption. So fluid pressure should be kept in our mind. And head and end of the table must be elevated by 5 to 10 degrees to reduce the chances of the cerebral edema and seizures.
Now he's nibbling the inner surface of the IAP.
So it is SAP and lamina junction, I think, or opposite side lamina, axillateral lamina.
See lateral.
We can see the direction of the hand to know the structure which we are nibbling. So our hand is slightly towards the operating side, and we are looking towards the spinous process. So the procedure which we are nibbling must be the upper lamina or lamina. So we can check it in X-ray where we are nibbling. Show the Siam shoot, and after Siam shoot one in AP only. AP only AP. Lateral. First AP and then lateral. हाँ.
You, if anyone wants to go have tea, you can go and come.